All right, welcome everyone to another Residency Hot Topics. I am very excited to be welcoming Dr. Rob Roy Martin to be our invited faculty today. Besides being a professor at Department of Physical Therapy at Duquesne University, he also serves as the editor for the Academy of the Orthopedic Physical Therapy Clinical Practice Guidelines. He has the great task of organizing the best and brightest across our profession to give us updates on clinical practice guidelines for our profession and others out there. So we have a very, very highly qualified faculty member today. And with no further ado, Rob, the floor is yours.
Thank you for that introduction. I hope I can live up to that. I'm going to apologize if I have any coughing episodes through this presentation. I'm recovering from a cold, so again, apologize ahead of time. Given the topic of presenting lateral elbow tendinopathy, and thought I would go through the clinical practice guidelines that we put together. Given this audience, I'm sure you know where you can find these, but I'm always amazed of the clinicians out there who don't know where these are located. So I always make a point to kind of highlight that these are obviously free and available on the JOSPT website as well as the APTA Orthopedics website for people's download and use. So try to get that out there as much as possible so that everyone can integrate these into clinical practice. So again, I will be talking about the lateral elbow pain, really lateral elbow tendinopathy clinical practice guideline that we published in 22. And I think one of the gems of these CPGs, and I'm kind of proud of, are these decision trees. So one of my main goals today is to really go over this decision tree in detail, kind of highlight what I think are important components of it. And then, we can talk about some of the nuances that are also embedded in here as well. So again, as we're all familiar with, we have our medical screening component, which leads into our examination, and then we have our intervention strategy. So just a couple pieces of low-hanging fruit that I'm sure you guys are familiar with, but there is some interesting information maybe related to some of the sensitivity and specificity of these tests. So as far as the Mausley's test, so this is really resisted middle finger extension. This has good accuracy behind it when we're trying to identify people with lateral elbow tendinopathy. There's also the resisted test or the Cosen's test. So resisted wrist extension, again, says pretty good sensitivity and specificity values associated with it. And then we also have the Mills stretch that, again, maybe not as good, but generally I think we can be pretty good at identifying when someone has lateral elbow tendinopathy, and we can supplement some of our diagnostic information with confidence based on these sensitivity and specificity values. But I think these are patients who really have this LET, lateral elbow tendinopathy, are pretty easy to pick up. So to me, these tests become a little more important in individuals who maybe don't have a straightforward clinical presentation. And we're trying to identify, maybe is there a component in a cluster of other pathologies that, in addition to having, maybe cervical radiculopathy or nerve entrapment, some peripheral nerve entrapment, maybe they also have a component of this. So to me, these tests become a little bit more important in someone who's maybe a little more complicated when you're trying to identify multiple pathologies. So obviously we do our medical screening. We're looking for people who are appropriate for physical therapy. We identified people with lateral elbow tendinopathies. So again, our clinical exam, we have palpation, and then we have our clinical tests to make sure that, we are indeed treating those folks. I do think it's important from a differential diagnosis standpoint. Obviously, if there's any concern at all for cervical radiculopathy, or again, as I mentioned, nerve entrapments anywhere else, we clearly want to make sure we screen for those conditions when it's indicated, to make sure there aren't maybe multiple pathologies that our patients are presented with. So again, making sure we're thorough with our differential diagnosis and not missing something along the way. Our treatment outcomes, so there are a number of patient outcome measures that can be used and are recommended in the clinical practice guidelines. So the patient-rated tennis elbow evaluation, there's the DASH. Obviously, we have our numeric pain rating scale. The patient-specific functional scale was also recommended, and then there's also the Mayo Elbow Performance Index, as well as the Rolls and Maudslay's score, which all have evidence behind it. Related to clinical impact, the DASH is one that can be emphasized because it has a minimal clinically important difference value associated with it. So that can be important, obviously, for our goal setting and when we're looking to identify changes in our patients, as a result of our intervention over time. This value can be important for us to use is to make sure our patient, again, is any change that they're making is clinically valuable. We also have our numerical pain rating scale. So here we're looking for, in this population, minimally clinically important difference of greater than 1 point. So if you're goal setting, you'd probably want to have, at least a 2-point change to be significant. And then our patient-specific functional score, we're looking for a minimally clinically important difference greater than 1 point. Excuse me. The patient-specific functional index or the patient-specific functional scale is one that I've become fairly fond and use routinely in really all my patients. This allows me to set and allows all clinicians to set really meaningful goals for our patients. So, I'm sure you're familiar with it where you have the patient identify activities or functional activities that are difficult for them, and you have them rate their ability to do that activity on a 0 to 10 scale. And that, not only can we pick up functional change, but functional change that's important for our patients. So this patient-specific functional scale is something that, I recommend to, patients or clinicians use for all patients. Now, physical impairment measures in this clinical practice guideline, there's been elbow flexion extension range of motion recommended, forearm pronation supination range of motion, wrist flexion and extension range of motion, radiant ulnar deviation, maximal grip strength, and then pain-free grip strength, as well as pain pressure thresholds. And one thing that you might notice that is not on here is resisted wrist extension. And, that was something that I brought up to the author group, who, I was really more of a consultant in preparing this information. I found it odd that, resisted wrist extension isn't something that was a physical impairment measure that was recommended. And it's felt that when you look at grip strength, both maximal grip strength and pain-free grip strength, that is a more accurate way to really look at the extensor mechanism and how it's functioning. And, I think if we kind of think about that in a practical application, grading, we're really, in this population, we're really looking for grades of 4, and whether someone's a 4 or 4 plus, or, maybe if you use a 5 minus, those values are pretty arbitrary and not objective. Where if we're using, a handheld dynamometer to get an assessment of grip strength, a little bit more accurate and more objective value than just giving someone a manual muscle test with wrist extension. So I think that's an interesting point that is kind of worth taking home. So if we take a look at implementing our outcome measures, those outcome measures that I mentioned before come with a grade A recommendation. So strong levels of evidence from high quality trials that, really recommend, one of these, either the DASH or other outcome measure to measure function. We have our pain scale and then our patient-specific function. So again, when we talk about levels of evidence, high levels of evidence supporting these patient-reported outcome measures. And then if we look at impairment measures, we get more moderate level of evidence, but still good, I think, in our profession. So a grade B still goes with a, kind of a should recommendation as far as what we should measure with physical impairment. Now, what I think is another jewel in this clinical practice guideline is, determining level of irritability. When I teach my entry-level PT students, it's something that we really try to get them to think about. And, someone comes in with really any orthopedic pathology, it's not just treating a diagnosis of impairments, that's obviously, important to get them to improve their function, but not all patients can be, treated alike. And we really need to incorporate the irritability stage to determine, how aggressive we should be and what intervention we should be implementing. Because, some of the older guidelines, for example, the Achilles tendinopathy, there's strong evidence that we should, that recommended eccentric loading. And you'll see that come up here, the same thing with lateral elbow tendinopathy. But that's probably not appropriate for all our patients, particularly those who might be more irritable. So I do think this clinical practice guideline, was did a nice job at defining irritability, and this is something I've really tried to carry forward with all the clinical practice guidelines as much as possible. Is really, how do we determine irritability? So here they talked about, breaking them into really four categories. So you have a symptom modulation category. So this would be defined as severe pain. And if we take a look at a type 3 distribution, we'd be looking at diffuse elbow signs and symptoms, maybe even diffuse through the upper extremity. If we have our mobility group, so now we're looking at more of a moderate level of pain, and you even see that these pain levels are defined, more diffuse distribution and a moderate level of disability. We have our loading group, which now we're talking about mild pain, our type 1 to 2 distribution, so more localized to the elbow, lower disability. And then we have our return to function, so our patients who have very little to no pain at all, that's isolated only to the elbow, and very little disability. So these categories of irritability really are used to drive our interventions. So if you can see, we get to this intervention stage here. We have our different treatments depending if you're symptom modulation. Again, higher levels of pain, diffuse symptoms with high disability. We have our mobility group. Again, our pain levels are decreasing, still relatively diffuse pain. Our disability is starting to decrease. Our loading group, so now we have lower levels of pain, more isolated to the elbow, and then our return to function. So here we're talking about absent to very minimal pain and very little limitation related to disability. So if we take a look at our recommendations and treatment, so again, as I mentioned, how do we define this? Our symptom modulation would be severe pain, diffuse elbow pain, and severe disability. So what would be some interventions for this group? So there was level B evidence, so moderate level evidence that we should use rigid taping for short-term pain relief. And here, this is an application, picture show an application of this rigid taping. And really what you're trying to do is you're trying to just offload that lateral epicondyle. So these 4 strips are laid onto the skin, distal to proximal in a diamond shape. And your goal is kind of to apply a traction force actually towards that lateral epicondyle. Usually these strips are going to be overlapped. And if you do it properly, they get what you call kind of an orange peel in the center. So you get that tissue kind of pooches up or become a little bit wrinkly, showing that you are creating some traction in that area. And if you do it well, you set this up as a diamond. It ends up in a diamond shape, and the patient should get some relief when that lateral epicondyle is offloaded. So as far as taping techniques, this has the strongest level of evidence. There is weaker level of evidence for kinesio tape. So this would, again, we're talking about our irritable patients if we want to offload that lateral epicondyle. So we're looking to decrease pain and improve muscle function. And here there's all kinds of different varieties of ways this can be applied, trying to offload that lateral epicondyle. Some simple ways that I find to be most effective is really you're just trying to use the tape as almost a wrist extensor assist mechanism and trying to offload that lateral epicondyle. Um, Again, I'm with related to these different kinesio tape application methods. It's not as well defined as the rigid taping, but what I would say is, when you apply this, again, these patients have higher level of pain, so when we put it on, they should feel some relief, and if you put it on properly, you'll get that result. And to me, it's kind of a you know keep working on different styles and techniques and putting various pieces of tape on until you achieve your desired result, which is decreased pain. So in my experience, this is one that I think kind of a wrist extensor offloading is one that I find to be helpful. And then as the patient starts to become less irritable, you can transition to less taping. But this kinesio tape comes with a little lower level of evidence in clinical practice than the rigid tape. We also talk about manipulation or mobilization techniques, and again, we making sure that we're looking at both the cervical and thoracic spine for any involvement. So regional mobilization could include cervical manipulation, side glides to C5 and 6, cervical or thoracic mobilization. So this could include your CT junction manipulation. There's a ventral scaphoid manipulation that can be done, and then radial head manipulation and mobilization with movement. We'll talk about the radial head manipulation and mobilization with movement. Really, to me, those two are pretty similar. And one thing, if we think about the anatomy of the common extensor tendon, it does have fibers that go over the radial head. So it's not unusual for patients to have tenderness over that radial head. And some mobilizations can be helpful to that, particular if we do some valgus or some varus gapping. So if we trying to do some varus gapping to increase or actually mobilize the radial humeral joint. And I think that this lateral mobilization with movement is trying to accomplish something similar. So here, where the mobilization with movement is as described in this slide, you're having the patient perform a gripping activity as you're performing a lateral glide to the elbow. So to me, one of the things we're trying to work on is creating or mobilizing that radial humeral joint with either lateral or varus glide. So the patient performs some gripping. Then we perform a glide without the gripping exercise. So typically we're applying lateral glide with 6 to 8 repetitions of gripping exercises, and then they also perform some wrist extension. So again, some evidence that this can be an effective mobilization for our irritable patients related to joint mobilization. As we get to our continuing on different interventions, we're again talking about our symptom modulation. So it makes sense that we would want to use, or would be appropriate to use, some modalities, which could include cryotherapy with electrical stimulation. We can also use anaphoresis with an anti-inflammatory drug, and this would be dexamethasone. And there is also weak evidence for laser. So each of these come with a lower level of evidence. So we're talking about, you know, what drives the C level of recommendation is, usually more cohort studies. These aren't randomized controlled trials. So again, lower level of evidence come with a less strong recommendation, more of a clinicians may use these different modalities. I do think it's important to note if we're talking about lasers, some of the parameters that are recommended. So again, we're talking about low level laser therapy. We're talking the red wavelength, so the 904 nanometers, and they're applying it to the common extensor tendon, the most painful area. The research has supported 9 treatment sessions applied, over a period of 2 to 3 consecutive weeks. So, with any modalities, obviously this is not applied for a long period of time, but I thought this is kind of helpful to kind of direct treatment. If you're going to use laser, what would be some parameters that would be recommended? And then ionophoresis, so our anti-inflammatory drug, is usually our dexamethasone. And usually this is, 2 to 4 weeks from the onset of symptoms when someone is highly irritable. As we move on to our mobility category, so now our patients, we're following them along the continuum. Our patient's pain level is starting to decrease. They still might have diffuse elbow pain, but their disability is improving. So now we're looking at, obviously, as the category says, trying to work on adding some strengthening. Some of the evidence talks about wrist extensor strengthening, that with weaker evidence for the scapula. And then we talk about dosing these. We're talking about, isometric loads or something that is, fairly low level, not to aggravate our patients. So again, this comes with the B level recommendation for whether isometric, concentric, or eccentric exercises. The key here with that, we're not aggravating our patients. With a lot of these tendon treatments, when we're providing exercises, they can actually, provoke a little bit of pain, but I always say that, remind folks that's different than aggravating. So you might have an increase of pain when you're doing the exercise, but once you stop the exercise, you don't have aggravation symptoms. So you can work with and into some pain, but again, not to be aggravated. The strengthening exercises should be included not in isolation, but with other therapeutic interventions. And then if we're taking a look at screening the upper quarter, we'd want to include shoulder and scapular stabilizers when appropriate, as to include it in the program. But typically, I think we would all identify that we would want to begin with, maybe some submaxillary isometrics, make sure the patient can tolerate that, again, not aggravating the symptoms, and kind of progress from there. I do think a take-home point would be as we're working on these exercises, it's valuable to keep the patient's elbow extended so that you're really maximizing the stress on that common extensor tendon. And then we would also work in multi-angle isometrics initially, and then progress to, easy, concentric, and finally eccentric as the patient can tolerate and as they move through our different stages. So again, I would start with our isometric, make sure we're not aggravating it, and then move on to more aggressive exercises. We can continue with our joint mobilization. So again, kind of continue if needed on the cervical and thoracic spine. Again, making sure there's no cervical involvement, our CT junction, our scaphoid manipulation, radial head, mobilization and movement. And with this group, our mobilization group, we can add a Mills manipulation to the recommendation. So again, kind of reminding us where we are. The patient is not highly irritable. they're not in symptom modulation, but working on mobility. A mobilization that can be added is the Mills manipulation. So here in this technique, you're holding the wrist. So again, this is a high velocity, low amplitude. So we're moving the patient's elbow into full extension, holding the shoulder in abduction, internal rotation, with the forearm in pronation and the wrist is flexion. So you're really, the movement is trying to get that elbow to be fully extended as you tighten all the tissue up around it. Again, more definitely in our mobility category, not our symptom modulation categories. This can be, aggravating for patients who aren't ready for this manipulation. Some other things that can be recommended in the mobility category would be dry needling. So this came with a B level of recommendation. So again, there are some randomized controlled trials that support this. So this can be used to treat pain and improve function in those with lateral elbow tendinopathy. So again, you can work on, whether you're working on trigger points, whether you're working on, tendon. And then I would also recommend, taking a look and making sure there aren't a central component to the symptoms. So, looking for, does there need to be treatment to the, C5, C6 central component with the dry needling, including upper trap, working the whole dermatome and myotome is often valuable in these patients. And again, this can also be done with electrical stimulation. So to try to enhance, if you're looking to elicit a twitch response, the electrical stimulation is a good way to guarantee that you get a twitch response, and can also be set up to enhance patient comfort with our needling procedures. Soft tissue mobilization comes with a lower level of recommendation. So far we have some things with grade B recommendation, including dry needling, our soft tissue mobilization, whether this be myofascial release, instrument assisted mobilization, come with kind of a May recommendation. So again, lower levels of evidence. There conflicting evidence was found for transverse friction massage. So again, that means that there's been some studies that would have positive effects, while other studies have negative effects. And I think we're all familiar with Graston tools or ASTIM tools. So whatever instrument assistive technique you'd want to use would come with a C recommendation in this group. Moving on to our loading category. So take a look at our patients in this category. Their pain is decreasing. So now they're having lower levels of pain, less than 3 out of 10. Their pain localized to the elbow and having lower levels of disability. And as this category indicates, we're going to focus on, strengthening of those muscles. So here we would, progress from our isometric, our concentric, and get into our more heavier loaded eccentric exercises. And really this loading relates to our, our subacute and chronic patients. So this is recommended. So there are multimodal interventions. I think that would kind of make sense to all of us, that we don't do our treatments in isolation, but our exercises, when they're coupled with our manual therapy treatments and other interventions, is how we're going to maximize the benefit. And then, screening for other upper quarter disorders and addressing those, whether they have shoulder scapularization, the scapular stabilizer weakness, might also be important to consider to add that with our wrist extensor strengthening. And again, I would just, as we move to this loading phase, start to challenge our patients and really focus on, a weight that now is, pain provoking, but not aggravating, and, you know, making this high load and really focusing on that eccentric contraction as we move through uh, progressing our way through these patients. So heavy loads that may cause pain, but not aggravating. And here we can get a little bit more aggressive. Our return to function patients. So these are our patients who have, you know, uh, mild or absent pain. Any pain they have is going to be localized to the elbow, and mild or absent disability. So here we're, obviously thinking about, if we're working on our patients, these are someone who's getting near discharge, and now we'd really want to focus on, you know, increasing that aggressiveness. So you notice that the recommendation for what we're working on is now that weights are certainly beyond 40% of their maximal voluntary contractions. We want to make sure we're establishing, neuromuscular control, working on reactions, and I think important in this group is our function specific tasks. So whatever the person needs to get back to do, we're trying to incorporate that as best we can into their overall rehab program.
Hey,
So
Rob, can
again,
I pause you for a question that came through in the Q&A?
yeah,
So, question was asking, certainly there's a large group of evidence that's in the B and C categories, but very little, if any, so far presented in the level A evidence. The question was, are there funding sources that are supporting this common MSK problem for that grade A sort of research?
yeah, that I'm not aware of. I mean, I think there's, the general funding sources. I just, a lot of the studies that are required to be highly random, if we're looking at level one studies, they're awfully hard to do in our group, because it's hard to blind a patient to whether they're getting intervention or not. I mean, that's something that's kind of hard to do. Um, uh, and often it's also hard to blind a therapist to whether they're giving the treatment. Those are kind of some of the cruxes to get really high level evidence, is kind of your blinding of the person who's administering the treatment, blinding of the patient who's receiving the treatment. And it's a little easier to blind the evaluator, but those three components, to get a high level one study are awfully, can be hard to do. But I do think those funding sources are out there. But truthfully, if you take a look at a lot of our clinical practice guidelines, I don't think that is unusual, in the fact that we have, not a whole lot of A-level evidence. I mean, there are things that stand out amongst all the CPGs, and that would be manual therapy and exercise. And then there are some level A that have come across for things like hip osteoarthritis. But for the most part, uh, most of the recommendations uniformly, other than exercise and joint mobilization, comes to that level B evidence. So, uh,
Thank you.
yeah. So just kind of getting back to this return to function. Um, Again, we're progressing that heavy load, and I think that the key to this is our emphasizing our functional work related exercises. So, I put a tennis player on here, not that this is tennis elbow only, right? But the kind of hitting the point home that, why would someone get tennis elbow? We need to take a look at their overall function. Is their grip appropriate? Do they have poor form? Are they overusing their wrist extensors? Is their racket strung too tight? There's a lot of different things that can lead to, this lateral epicondyle, uh, the lateral elbow tendon here to be overloaded. So I think it's important to make sure that, we're kind of not just treating that area, but, making sure we're doing a thorough job of identifying any contributing factors. What is tight, what is weak, and if we're thinking about an athlete, that might include an entire lower quarter screen as well, to so that we're not just getting too focused on here. And that's sometimes, in my experience with the dry needling, making sure we're not forgetting the kind of some of the central mediators that can be, contributing to pain in this area, and some of the muscle inhibition uh, related to myotomes in that area. And then, obviously our athletes, but also our, any worker who does a lot of high level grip activities are also going to be potentially at risk for these problems as well. I think as we, move through here, we're obviously always going to reevaluate it. Our patients hopefully are going to be progressing through our program. So moving from symptom modulation to mobility to loading to, to our functional recovery groups. Hopefully they're moving through those in an appropriate fashion. If they're not improving, we'd want to make sure that we refer them to uh, uh, other healthcare providers, but obviously we're going to make modifications and progress our patients as appropriate. At some point, hopefully our patients' goals are met, and we can discharge them to successful recovery. And this is a chronic condition, and most of our patients who we see, generally don't get to be 100%. If you work with this population, they're kind of they call it acute on chronic condition, where you get better and then you kind of aggravate this. And I think one of the key things here would be to, make sure the patient is independent with self-management. They kind of understand how to modify their activities. And I think, kind of going back to that functional retraining is trying to identify why they got that, and that why they got the lateral elbow tendinopathy can be helpful in, kind of preventing aggravations of this. So there's actually, principles for practice, which is the most boiled down template of all these. So kind of our bottom line for clinical practice. So for symptom modulation, we should use strategies to offload our tissues. So this comes with a variety of levels. The taping comes with a B level of evidence. We want to manage the impairments, consider joint mobilization and physical agents if needed. They move to the mobility category. We can do our soft tissue mobilization with our augmented, again, whether that be A-stim or GRASSTIM. There is grade B evidence for dry needling. So this does come with, some randomized controlled trials that have driven this recommendation. And then once we get to that strengthening and functional capacity, we're really trying to increase progressive resistance throughout the upper kinetic chain to try to restore function. That's all I have on lateral elbow
Awesome.
tendinopathy.
Thank you. Yes. And what we'll do for everyone who's on the call, the chat feature is enabled. So feel free to start throwing some questions in the chat. Rob, you can stop sharing your screen if you'd like, just so you can see the chat questions come through. And then I'd like to start maybe with a question that I hear a lot from our residents and our own clinicians, and that's, as the editor of the clinical practice guidelines, obviously trying to balance the evidence-informed care with the art of care as well. And as a clinician and a teacher and a mentor, you obviously do a lot of that. So what are your thoughts on, as someone takes this data from the clinical practice guidelines and wants to apply it into their practice, where does it fit in the context of your practice, and what do you recommend for others as well?
Yeah, I mean, that is a great question, and one we, get almost all the time, right? And I think that, some of the keys is when we're working with patients, we need to try our best to use the evidence as appropriate. Like, not all patients are going to, for example, dry needling, right? Maybe someone doesn't like needles, and it's something we can't do. So evidence-based practice excuse me, I think of as a three-legged stool, right? You have the evidence, you have your experience, and then you have what the patient wants or desires. So, the evidence is really just one leg of that stool, and you need to take that into consideration. I would say when we know the evidence, we got to justify, why can't I do this? Why shouldn't I do this? And then if we're doing things that are outside of the guideline, kind of the opposite question is, do I really need to do this, and how do I justify it? So I think you can do things certainly outside the guidelines, just needs to be, justified and documented. And I don't think you have to follow the guideline. Again, just again documented, based on patient preference and your experience. So I call it
Well said.
guardrails. Yeah, I call it
Well said.
guardrails.
Yeah.
It gives you guardrails what to do, and you got some freedom in it.
Love it. Yeah, I like having the evidence platform to go from, right? If you're doing all those things and you're doing them at a high level, you're doing them extremely well, it gives you then the freedom to explore beyond that and try things if it's not working all the way. So, a couple other great questions just came through. One, what are your thoughts on blood flow restriction training in elbow tendinopathy, given emerging evidence since the CPGs were publicized?
Yeah, I mean that's a great one, and I would love to see some research done on that, because just from a experience standpoint, I really think that can be super valuable, particularly when we can't load, right? Or want to add loading. I mean, BFR, I think, allows us to do more with less. And I certainly think, although it didn't turn up in this guideline, again, that would be one of those things that I think you could clearly justify based on clinical practice. I can't add the load I want to get this change. Let me add BFR to it. So in my experience, I think it's very valuable. Evidence hasn't supported it yet. So it just means I would use that as another tool in addition to all that we talked about, and incorporate that with loading.
Yeah, especially upper extremity, it will burn you out so fast. It's crazy.
Yeah, yeah.
And another question from that same thread, any thoughts on shockwave for LET?
Yeah, I mean that's something that I've kind of struggle with, even I'm not 100% sure where that falls in our practice guideline. I know some therapists do it. I know they get cash payment for it, but I'm not, I haven't found a definitive answer, and maybe someone knows on this chat, what's our professional stance on it. It's not something I teach as an entry level. I know that internationally therapists do it, but I from a APTA standpoint, I haven't found a strong stance on it's something we should or shouldn't teach, and where it fits into our clinical practice. And if anyone has an answer to that, I would save me some trouble in continuing to dig, because I haven't really found a great answer for that. Uh, so, I mean, I think with a lot of these tendon issues, it's something that is, something that can be, kind of, if they're not getting better, something to try. And whether you feel comfortable and qualified to do it would be something to try. Whether or not you think you need to refer to another practitioner, that would be, another idea.
Excellent. Another question, what is your response to patients asking about PRP?
That's another, I think the PRP is kind of a flip of the coin. I tell patients that the worst thing you can lose most often is money, right? Because a lot of them are cash-based services. So if a patient is kind of at the end of their rope and not getting better, the downside in my experience is just it's a cash. So there isn't, some patients it's a miracle, some patient the whole gamut, right? You can either be 100% improved with it or 0%, and you kind of run that whole spectrum, curative or doesn't give you any benefit at all. So I would tell patients to hold off, and if it's something that they're unsatisfied with their status and don't really see an end out of the tunnel, something to consider, and recognizing that your only downside would be would be the financial aspect that you would lose from it.
Excellent. Next question. When you say you load these patients, how heavy are you loading the elbow and wrist?
Yeah, so it's particularly when we get to our functional and in the loading phases, you know, I really try to pick a load that, actually causes a little bit of pain, right? So, when they're doing it, it's not a comfortable load. And I think that's one of the things as therapists that we often do is underload our patients, right? Particularly when we're getting in, we don't have to be that concerned about, aggravation, right? So, I use the Achilles guideline, and I carry it to this is if you're having a 5 out of 10 pain, I can live with that, 5 or under. If you get above a 5 while you're doing the exercise, that's probably too much. So I try to load it to provoke some pain, not more than a 5, and kind of always reevaluating is this bothering you or not. But some key things that I think is to keep the elbow extended. Again, a lot of patients make, or a lot of, patients get sloppy and do more of a bent elbow. I think to really maximize your load, that elbow needs to be in full extension to maximize that.
Excellent. Any other questions from the chat as we finish up here with Rob? Saw a couple comments here supporting the use of Shockwave with their regenerative medicine team. Another supporting the use of ultrasound guided dry needling as an alternative to PRP with similar evidence.
Yeah, I do think Shockwave is, again, if feel qualified, it's not the same obviously, but your greater trochanteric, tendinopathies respond well to shock therapy. So to me, it would kind of make sense, your plantar fasciitis, your Achilles, all these different tendon groups, I think, would have a potential similar effect. In my experience, I just haven't found the need to do it. Most of these patients get better with my traditional physical therapy. I mean, there are a few outliers who may benefit, but I think, kind of the traditional physical therapy road is generally what gets patients better.
All right, fantastic. It looks like we got one more in here. Oh, two more. We got some speakers coming through. You may have said this, but why do you think scapular strengthening stabilization had such a low grade on the CPG?
Again, it's probably more the evidence, related to the studies. First of all, how do you identify scapular dyskinesia objectively, consistently, reliable, and valid? I mean, we all think we see it, but to what degree? And then to me, the bigger things is picking up a change, right? Like we see scapular dyskinesia, but how does it improve? Can we pick up a 10% improvement, 20% improvement? I think we know it's normal and abnormal, but there's a whole lot of gray in there. So, and then I don't think that's a common problem with all patients, right? I don't think all patients have scapular dyskinesia that leads to this issue. So again, it's kind of, I can't recall the exact details of the study, but if you throw scapular stabilization, everyone with LET, you're not going to get a result if they don't have scapular dyskinesia. So I think you need a study that might have a more tailored approach where you say, okay, this is how we're identifying scapular dyskinesia or weakness. We can pick up this change, so we can identify the subgroup. We give this intervention to the subgroup and they got better. So.
Question here on, do you feel the diagnosis of ECRL versus ECRB tendinopathy changes the course of treatment with exercise?
I would probably say no. I don't know if I can really confidently distinguish between the two, and I might say no. There are other, maybe there are some who would disagree with that, but generally I don't think so. I also see the question about the counterforce brace. Yeah, they're just not, it didn't come up in the clinical practice guidelines. I do think the two taping methods, particularly the rigid tape, is something that can be helpful. But again, the counterforce brace is another one that just because the evidence is there doesn't mean you never use it. If that's what gives the patient comfort, that's what you use and you document it. So I would not use it. I would, that wouldn't be my first line of treatment if a patient wanted to try it, when they weren't benefiting from the other offloading techniques, certainly something to consider.
Yeah, I think a lot of the interpretation of the clinical practice guidelines is founded in the method that's being used and how things are being graded and what made the cut and what didn't make the cut based on that criteria. So, not surprising that, as you mentioned, it's a common question that's brought up whenever trying to interpret the guidelines just in general.
And I always like to say, if someone feels strongly about anything that's not recommended, part of the purpose of these guidelines is to stimulate research. So, if you're passionate about something, you say, hey, this works on my patients. Some of the purpose of these guidelines is to up the evidence. So if your, therapists are disheartened by the lack of evidence on any of this stuff, to me, the purpose of these is to get things going, right? Like I know this works. Let's do some research on it. So that's, I think, part of the value of these is they can show holes in the literature and where we need to strengthen our research.
And I would agree and add maybe even volunteering on the group that creates the guidelines because as I
Yeah,
look across the chat, there's a couple very prolific researchers in the chat, so I know they've got a lot to offer as well.
yep. Always more the more the merrier. There's not a lack of work that needs to be done, and we can happy to share as much as possible.
I'm sure you would be happy to have more smart people in your on your team.
That's
Well,
right.
Rob, with no further time, wanted to thank you so much for all of your effort and for volunteering not only as the editor for these clinical practice guidelines, but also as a faculty here tonight. Big shout out to you and all the hard work that you guys have done. And for everyone who's on the call, everyone who's watching the recording, stay tuned for our next topic. It comes up next month. We'll have Julie Fritz on to talk about low back, one of Rob's colleagues and close coworkers for sure. And feel free to also look at the repository of all the other videos on the YouTube channel when I send out this recording. Rob, thank you again. Thank you for all who attended and have a great evening.
Thank you.